welcome to SurgiColl, the podcast. SurgiColl, which is short for Surgical Collective, is the first open access journal focused on publishing the latest evidence-based literature on the surgical specialties. The journal publishes quarterly and includes peer-reviewed original research, systematic reviews, current concept reviews, case reports, and surgical techniques. Today, I'm looking forward to our discussion on a recently published article in SurgiColl titled Acute Management of Open Long Bone Fractures, a Scoping Review. And in addition to discussing this article, we will do a deeper dive on some of the latest indications and controversies around open long bone fractures of the lower and upper extremity. Today, we are joined by Dr. Saqib Rehman and Dr. Brianna Fram. Dr. Saqib Rehman is a senior author of our paper today. He's a professor of orthopedic surgery and the director of orthopedic trauma at the Temple University Hospital in Philadelphia. And Dr. Brianna Fram is our guest expert. She is an assistant professor of orthopedic surgery and is an orthopedic traumatologist at Yale in Connecticut. So before we get into the article, I'd like to get started by maybe asking a few questions for our listeners just to get a little background on each of you. So starting first with Dr. Rehman or Saqib, if you don't mind. So since you're being the author of this paper, just curious, so what inspired you to get involved in clinical research? I know you've been in academics for a long time, but just broadly, what inspired you to get involved in clinical research?
Well, to be honest, it's because I took a job at an academic medical center. I think once I realized that I sort of fell into a job as a full-time academic person, I just always felt, you got to do your best in the job that you're asked to do. And part of being an academic faculty is to do research. So if I had gone into private practice or possibly an employed position, other opportunities I had potentially lined up, I might not have been doing research. So it's really just, hey, I'm in academics now. Got to sort of do as good of a job as I can. And that means also doing research. So that's kind of where it started. Literally my first year as an attending, I was getting involved in more research than I had as a fellow or resident, really.
Well, I can vouch for the fact that you've definitely done your part in, participating in clinical research and leading by example. So I commend you for that and for this paper we're going to be discussing. Dr. Fram, Brianna, let me ask you a little bit about yourself as well. So tell me about what drew you to your choice of surgical specialty.
Yeah, I think a lot of trauma people might agree that the variety and the fact that people are coming with sort of acute, less elective injuries is part of what draws them to the field. I like doing open surgery. I like operating all over the body. I think I found specialties where it was same or similar procedures over and over again, a little bit tiresome, whereas others find the variety and sometimes chaos of trauma a little bit stressful. That didn't seem to bother me as much. So yeah, and it's kind of nice taking care of people when they're in a time of need and having slightly more clear-cut indications. I think it's easier mentally to deal with complications when you feel like it was an extremely well-warranted procedure that you recommended for an acute fracture with clear indications than it is when you do an elective procedure on someone and they have a complication.
Yeah, no, Brianna, I would definitely agree with that. We just had this discussion recently with some house staff about elective and trauma cases, and there's many differences and there's many things that are advantageous about both elective and kind of trauma cases. But one of the things that indeed is when you have an elective case and there's a complication, it's much less tolerated, and whereas in trauma it's a little bit different in terms of, I don't want to say the word tolerated, but almost sometimes a little more acceptable depending on the dynamics that are in play. So it's a little bit more forgiving in that way, relative to a clinician. So I broadly agree with you in that assessment. So, and I know you're doing a great job up in Yale as well. So before we get into the article, let's talk something a little bit fun, just real quick. I always think it's kind of a fun topic. So just curious for each of you, what is or what was your favorite or most hated medical TV show or movie growing up, and why? And for a lot of people, we who are in medicine, they often hate these shows, and other people really like them. So curious what you guys think about that.
Brianna, you want to go first?
Sure. Yeah, I think Scrubs is my clear favorite. It's probably the only medical show I've watched extensively, and it's not supposed to be one of the realistic ones. It's a comedy, not a drama. But I just really liked the characters. I think I watched it when I was in high school, and Dr. Cox in particular was the one who made me consider wanting to be a physician. So
Nice. How about you, Saqib?
I guess I'll go with a movie. I was thinking of when you just said this, Flatliners comes to mind, just because I still think about, what happens, in that moment, and if you come back, have you really seen the other side? And just that whole, it's a sci-fi, obviously, but clearly there's some medical basis there. So I still think about the concept in that movie, but I really don't watch a lot of medical movies. I'm finishing reading the autobiography of Anthony Fauci right now, by the way. I'll say that is amazing. And I'll just say, as a physician, I feel personally attacked when I see Anthony Fauci getting trashed, even though I know a lot of people, maybe some of us here, did not like being told what to do during the COVID-19 pandemic. I mean, the guy's a legend. He truly is a clinician scientist legend. He's won the Presidential Medal of Freedom. He was one of the lead architects of the PEPFAR initiative, which saved 25 million people. He's taking care of AIDS patients before people knew what it was. So anyway, I'm in the middle of reading it now, so I'm kind of excited about it, but put in a plug for that book.
I think, not to get controversial, but I agree with you. I think some of the attacks on him have been really hard to fathom, frankly, and kind of misguided. So great plug, and
another podcast episode. We can chat about that.
That's right. That's a whole other episode sometime, right? But Flatliners was a good one, by the way. That's a really good one. I wasn't expecting that one, so that's good. So let's jump into the article a little bit. And Ellen, I don't know if you were able to put it up briefly. We can put it up for a little bit and then take it back down again to discuss that just a little bit. So Dr. Rehman, so the article is a scoping review, I think, focusing on best practices in the acute management of open long bone fractures. Your study included about 69 articles, I believe, for review, and you identified a number of common findings relative to empiric antibiotics and surgical timing. My first question to you is, what findings surprised you? Or if you want to just summarize what you think are the most important takeaways of the article. And then my main question is, what findings really surprised you? And how has it informed your subsequent evidence-based recommendations in your practice?
You're muted.
So to take a brief summary, I would say this is not only about antibiotics per se. We tried to look at all the factors you take into account when managing an open fracture. So we looked at timing, antibiotic choice, antibiotic duration, and then timing of debridement. We looked at irrigation types and technique of irrigation. And then we looked a little bit at ballistic fractures, which is a type of open fracture that really, I think a lot of centers don't have a great handle on what pathways to use for that. I think what surprised me when we decided to do this, and I would say a little background just to go behind the curtains a little bit. This paper came about really almost initially as I guess I wouldn't say maybe like a performance improvement initiative, really. We were due to update our institutional open fracture protocol, which had been several years old, maybe 8-9 years old, and we really wanted to do as good of an effort in coming up with what are the current best practices. And we're starting to see some guidelines coming out, especially for antibiotic choices from the Academy, for example. But kind of holistically address all the issues I talked about. So we were really updating our protocol, and that's kind of where this came about. And in the process, said, look, so we kind of have a review paper here, really, and we can report this to share our results. So that's how it came about. One of the surprising things I found was, and maybe this is just being ignorant, was the evidence for cefepime, just not an antibiotic that I've really had used a lot in my practice before.
Right.
and seeing how much evidence there is for cefepime, especially in the type 3 open fractures. Another interesting finding worth sharing is, gentamicin, which, when I was in residency 20 years ago, and certainly in our most recent protocol, actually, until our newer one, it was still being used for type 2s and 3s. And I don't think there's really evidence showing that it's a bad drug. I think one of the issues, we all know they're renal issues, but one of the issues that we found in our center and other places reported is it's weight-based. And if we know that timing of antibiotics is critical, like how quickly you give it makes a difference.
Right.
It should be given in the ER, maybe in the trauma bay. So you can grab a bag of Ancef because it's right there.
Right.
The gent has to be weight-based. And inevitably what happens at our place and many other places is you got to kick it up to the pharmacy. They have to prepare it, send it downstairs. So there's delays. And it's not just, I would say, it's institution-based, but it's widespread enough that we feel like there's a problem potentially using something that's weight-based like gent. So those are a couple of things I found were interesting.
Did it change what you guys are doing at Temple in terms of managing open long bone fractures?
Yeah. So certainly we've updated our protocol, and I think in the paper we have a little flow chart, like many other papers, at least for antibiotic types, or antibiotic treatment, where it goes through what we would do for type 1, 2, and 3. So that's currently what we're doing now. I can't tell you yet exactly how well we're doing. We're just starting to look at our data now since implementing this, which has probably been in the last year and a half, perhaps. And we can certainly report back on that. But it has changed. For instance, we've gone away from gent. We've gone to using like 2 grams of Ancef kind of as a sort of average standard dose instead of 1 gram of Ancef. And we've gone to Vancef Triaxone in most of our type 3s.
Got it. Brianna, let me ask you, so building on what Saqib was saying in his experience and what he published in his review, one of the areas that there's a little bit ongoing controversy is around managing open fractures. If it's let's call it a traditional open fracture versus say a gunshot or a ballistic open fracture. Does your kind of approach differ? And then Saqib, if your paper had any details on that, please let us know.
Yeah, so my approach definitely differs. I loved the fact that you guys included ballistic fractures as open fractures in this paper. There's basic science evidence where they basically, took bullets and shot them, and then cultured the gelatin that they shot them through after inoculating the bullets with the Staph aureus, and showed that the heat of the explosion does not sterilize the bullet. So we know that that's a myth, that the bullets are not sterile, and obviously they're also contacting the skin and dragging stuff in, and so they are open fractures. I actually did a decent amount of research on ballistic fractures as a fellow, some of which is pending publication. And so it's the same questions, right? It's about antibiotic timing, which antibiotics to use, duration of antibiotics, and then should you debride? And if so, how aggressively? Should you be debriding down to the whole bullet tract and debriding the bone, or should you just be doing a superficial thing so you can close a wound and not doing a deep debridement? And our institutional results from fellowship did seem to support the papers you cited here, that deep debridement was actually a risk for deep infection and non-union. But again, you bring up the point that it's really hard to classify ballistic fractures in terms of, we know the Gustio-Anderson system has poor interrelated reliability, and most of us don't feel that it's an appropriate classification system for ballistic fractures, so we can't even use our poor interrelated reliability system for blunt trauma on these injuries. And so doing research is it's so hard, right? I mean, it's hard for open fractures for all the same reasons. Is that one person thinks that every open tibia with any wound that doesn't seem to be just a poke hole is immediately a type 3, and another person, thinks that there are type 2 open tibia fractures and everything in between. And I think the muddying of the waters is as bad, if not worse, for ballistic injuries right now compared to blunt open. But I do treat them differently. I'm less aggressive with my debridements. and with antibiotic prophylaxis as well. In part because the soft tissue injury is less severe. I think that's why if you summarize some of those studies, which you guys did, the takeaway is kind of you can have as severe of a bony injury, but the soft tissue injury for the low velocity ballistic injuries tends not to be as severe. And so, the rates of non-union and infection tend to fall somewhere a little bit lower than the equivalent bony blunt injury because blood supply. So that's just me.
No, that's great. I appreciate that, Brianna. I think you elucidated some of the really big kind of controversies and difficulties in comparing a traditional open fracture from a ballistic open fractures. And in a lot of ways, they're similar. In a lot of ways, they're different, indeed. And it's amazing when you go from center to center how people think about them entirely differently as well and treat them entirely different as well. Saqib, for you guys, and a traditional open, let's just say, a non-penetrating open fracture versus a ballistic open fracture, how do you manage that from both an antibiotic perspective and a surgical perspective? In terms of, when I say surgical, I mean wound management.
For ballistic injuries.
Yeah, ballistic versus, say, a non-ballistic.
So I agree with everything Brianna said, and we don't have good evidence to guide us with this. We don't have a great sort of wound classification or open fracture classification for ballistic injuries that's widespread and utilized. I tend to stick to actually using Gustillo-Anderson classification because I think people know it at least. And I think that to some extent, it's not exactly the same, but a wound is a wound. And if there's, if I have a 10 centimeter wound, it's probably a really high energy gunshot injury. And if it's a less than a centimeter wound, I probably, most likely don't have the highest. It's probably not a AK-47 or some type of shotgun. It's probably a low caliber pistol or something like that. So it's not it's not the same as your blunt trauma, but I do tend to use that, and I think that there's familiarity with it. I think the problem is when people think that, okay, this is a gunshot injury, therefore, it's not really open. I always feel like I have to correct people with that. I mean, it's open, there's a wound. So that's another reason why I say, maybe just use Gustillo-Anderson classification. And if it's a tiny wound, it's probably, a lower risk for infection. You probably don't need to have to do a third or Briedman. And if you have a big, huge wound with a lot of soft tissue injury from a gunshot injury, you can't say it's a gunshot injury. I'm not going to do any. It's a gunshot. It's not open. I mean, look at it. It's open. It's a huge wound and it needs some treatment. So I kind of go with Gustillo and treat it that way.
To play devil's advocate, Saqib, though, I think that the difference is that, with the traditional open injury, the bone is exiting and re-entering versus it's strictly penetrating. I think that's where a lot of that controversy is fraught from.
Yep.
But I think both of you, have highlighted that it's such a heterogeneous group of injuries, both based on size of wound, energy of the injury, ballistic capacity, et cetera. So many variables that go into it, and it creates a lot of controversy around it. I think it's best to have a relatively consistent kind of treatment algorithm whenever possible, but it's not always, I guess, possible. Let me ask you guys about timing to the OR. So we talked about antibiotics, and I think broadly there's not a lot of controversy around which antibiotics to use as long as there's consistency within the institution and evidence to support it. But timing to the OR is one where there's continues to be controversy. And most of us are still very familiar with the 6-hour rule for open fractures. Any comments on that, Brianna? You want to take that first? Like, how do you advise your team when? I'll give you a scenario. Let's just say there's a 3 centimeter open wound mid leg over the tibial shaft, an oblique tibial shaft fracture. It's an open tibia 3 centimeter wound.
Yeah, I do tend to stick to the sort of more within the 24-hour timeline. But if it's a very large wound, or there's it's not just an open wound, that's obviously a fracture wound, but we are looking at bone, or they can easily probe deep to bone through that wound, that degree of soft tissue injury, or any gross contamination. I typically do take those cases as sort of a level 1 or level 2, which means within 1 hour or within 4 hours, because I just think if there's that degree of gross contamination and that degree of soft tissue injury, not only am I that much more worried about infection and contamination, I'm also that much more worried about the patient's neurovascular status and about the long-term condition of the soft tissue. My general philosophy about a lot of this stuff is like biology is king, right? Open fractures go on to non-union and they have an increased risk of infection in large part because of the local stripping, right? Lack of blood supply, lack of ability to deliver local antibiotics, and obviously to heal the bone with blood supply. So to me, the more severe the open injury, the more emergent it is, because I want to wash it out faster. I want to put local antibiotics in the fracture site. And obviously I want to assess the surrounding soft tissues, get them cleaned. And if I can remove anything that's dead or non-viable and get them under some sort of tension to decrease the chance I need to do a flap later, those things are playing into the time calculation in my mind. So for type 3s, I am taking them sort of ASAP. For type 1s and type 2s, unless there's gross contamination, I try to stick within the 24-hour window. Got it.
That seems really reasonable. I mean, Saqib, do you think about it a little differently at all, or about the same?
About the same. I think what we mentioned also was 24 hours, and the Academy guidelines on timing of antibiotics is also 24 hours. I think it's a moderate, maybe not a very strong recommendation, but and I keep saying guidelines, I'm talking about the AAOS clinical practice guidelines. So there is one for timing of antibiotics, or just antibiotics with open fractures, I think, or infection prevention with open fractures. It covers more than antibiotics. So it's 24 hours. Yeah, I mean, I think it's, 6-hour rule is probably, I think most papers have kind of debunked that. That being said, there is some evidence to suggest there's a time dependence to some extent with infection rates going up. There was a meta-analysis called the Goliath study, in which it's really a meta-analysis, but by looking at papers that were published, they did demonstrate a time dependence of infection rate going up slightly over time. There's probably an even better paper that came out in the JBJS, actually from the sign, the sign nail. So you're looking at like 50 or 60 countries and resource poor environments. Yeah, Dr. Zirkel's one of the co-authors, and it was like 10,000 patients, and they had great records because they had to require everybody to send in records with, I think, at least certain amount of follow-up. But they had the times to debridement, and I think certain patients were like, if you were a week out, they excluded you. But they also showed a very slight time dependence increase, but it's like 0.2% per every 6 hours. So meaning, like, yes, the timing's important, but as long as it's not grossly contaminated, 24 hours is fine. And there's other reasons to treat an open fracture, right? I mean, you got a patient with an unstable, like Dr. Fram said, I mean, there's soft tissue injury, this patient in pain, you have an unstable, long bone injuries, a lot of other reasons you have to go to the OR other than decreasing infection.
Right.
And if you're grossly contaminated, I think it's a problem. I think the other issue also becomes a practical issue. I think a lot of times we talk about timing of open fractures, and we'll have these case seminars, and someone will say, well, you can put that case on for the first case in the morning. Medically speaking, that's probably totally fine. Practically speaking, well, what if you have like 4 elective cases starting at 7:30? Now you're going to just bump the whole day. So that becomes an issue too. Practically, do you really have a spot to put that patient first case or second case? And you're not getting it to the end of the day and then you get bumped. And now it's more than 24 hours. So nobody talks about that, but that's also something they got to consider when managing these.
There's so many variables, and it's amazing that at this point, we try to follow evidence-based medicine, but even so, there's in such a common issue such as an open fracture in orthopedics, there's still so much gray and so much controversy. When I speak to my own team members around these injuries, be it ballistic or non-ballistic open wounds, you have to look at it from so many different angles. You have to look at it from the patient characteristics, the wound characteristics, the fracture characteristics, timing and access to the OR, like you mentioned, resources, et cetera, that are available to you at that moment. Luckily, most of us have quick access to antibiotics, and we know that makes a lot of sense to get that going. But the other things, there's so much gray in terms of how you manage. And then, in terms of like how bad the injury is, how many other injuries there are, that a polytrauma situation, et cetera, et cetera. So many different things. Let me ask you both a question. Does your thought process, and I know this is very broad, but just kind of some broad strokes, if you're willing, does your thought process in the management of open fractures, and we'll focus on long bones, differ when you're dealing with an upper versus a lower extremity fracture? So let's say we're talking about that same injury, and I'll have you, Brianna, go first. A 3 centimeter, let's say posterior wound in the brachium, or there's a midshaft open humerus fracture. Let's say no radial nerve involvement or palsy, I should say. Does your thought process change at all in terms of how you manage those, say, versus, say, the tibia?
Well, I'm definitely less worried about it if it's an open upper extremity and there's, no neurovascular compromise, just because, again, vascularity tends to be better in the area. And so we tend to see lower infection and non-union rates. And I also think those injuries are less commonly grossly contaminated. But we certainly see like enough mangled limbs from ATV rollovers and patients with the arm out the car window in the MVC. And I've had a couple mechanics who had things blow up, who came in with mangled upper limbs, who had, engine oil and stuff and tire debris. But I think they're also less likely to be contaminated grossly, just because, I think a lot more of those injuries are happening within a contained vehicle. So I don't treat them differently necessarily. I just have a slightly sunnier outlook on the expected outcome with the equivalent upper extremity injury.
I like that. I'm going to use that. I have a sunnier perspective when it's the upper versus the lower extremity. Saqib, what do you think? Anything different in your kind of approach to these injuries if it's upper versus lower?
Yeah, not a lot different. I think that we kind of have a similar approach. Some of it may be dogmatic to some extent. We're kind of always just taught, it's just not going to be as much of a problem. And I think practice is, I've seen very few open fractures in the hand, for example, go emergently to the OR, and because the hand's so well perfused. But then I always ask myself, well, then how come hands are always getting infected? And I see hand pus all the time when I'm on call, but it's so vascularized, right? I guess it's because you're sticking your hand in bad places. But I mean, so yeah, I do treat it differently. I would say a similar approach to what Dr. Fram said. And I just don't know how super evidence-based that is.
Right.
Well,
so much of what we do is the art of medicine, and just having a sense of what's going to be, what needs more, what needs less, et cetera. One more question for you guys, and then we'll do one wrap-up question. We always talk about surgical debridement, but I find there is enormous variability in the physical debridement of an open wound. Sometimes when people are saying surgical debridement, they're just literally washing out a wound, and there's other folks who are doing really extensive debridement of skin, subcutaneous tissue, muscle, periosteum, devitalized bone, obviously removing any contamination. How do you advise your teams? Both of you are working at academic centers where there's house staff involved, and how do you advise them to think about a quote-unquote debridement? Because the other thing that limits your debridement is if you're too aggressive, then you have problems with wound closures and bone loss, et cetera. Saqib, you want to go first?
Sure, I can go first.
Yeah.
It's a great question. I think that debridement is clearly important. You're trying to prevent infection. You're trying to remove, obviously, gross contamination. So, I mean, there's debridement at multiple levels, right? You mentioned a lot of the different tissues we have to think about. So first, obviously foreign bodies, gross contamination. Sometimes if you're asking from a technical standpoint, usually it's, a knife, scissors, stuff like that. Occasionally, if it's like dirt and ground material, I find sometimes that hard to remove. Sometimes a VersaJet type tool is actually very useful for that type of sort of ground in material. I would say that on the initial debridement, I would say moderately aggressive. I'm probably not as aggressive as some. I will leave tissues that I think are, marginal. I've seen tissues come back. I'll leave bone that I think is marginal initially as well. So I'm not usually going in and taking out everything that looks questionable, biologically questionable on the first go. And then when we come back, I might choose to do so, but I would say moderately. And, when you look at the evidence, not great evidence, but there's some evidence to suggest that, taking every single piece of questionably devitalized bone out may not always be the best choice, at least in some parts of the body.
Right.
Because ultimately you still have to reconstruct that, and that's not a free lunch necessarily, to come back
Exactly.
and rebuild all this bone.
Right. Brianna, any other different thoughts or additional thoughts on that?
I mean, I agree with everything Dr. Rehman just said. I think it's all Harani et al. I have a couple of papers. That's the group out of the UK that I think of about publishing on, within the last 5 years, maintenance of structurally important pieces of bone that might be completely devitalized in open fractures. And they've shown fewer repeat surgeries, lower rates of infection, lower rates of non-union if you can get those devitalized fragments really, really, really well cleaned and re-implanted as essentially autograft. So I'm also intermediately aggressive about debridements. I think there's a sweet spot, same deal, where if you remove too much tissue, you're devitalizing further, you're creating need for wound coverage that may not have existed before, and a lot of tissue does declare itself. I'm also pretty aggressive about at least putting gentle tension onto surgical wounds and trying to get them approximated whenever I think I can. I have some partners who like to leave things open. Tissue loses tension so quickly. By leaving a wound open instead of just putting gentle tension through it, that tissue is going to contract into that position, and it may never be mobilizable again in a way where you can then close it primarily. Otherwise, I agree with everything.
There's moderate evidence that you should close what you can.
Yeah.
And I think those are also, Academy guidelines as well.
I mean, we're discussing this topic and as foundationally based on a paper published by Dr. Rehman, and we obviously espouse pursuing evidence-based approach to medicine. And it's for those out there listening who are curious why there's so much gray. There's just so much variables in terms of trying to study this. The location of the injury, the extent of energy of the injury, the soft tissue injury, the bony injury, patient-host dynamics, comorbidities, other associated injuries. Such a heterogeneous issue. So much of it is a combination of variables that you have to take into account, with the ultimate goal of trying to be avoiding infections and getting the bone involved to heal. So it remains a challenge. So based on that, as a final question to each of you, and building off of this article that we're focusing on, what do you think is some future direction for research on this topic? And Brianna, I want you to go first because you mentioned some of the work you've done in this space. Is there areas where you're particularly passionate about, or you think there needs to be some really deeper work? I mean, there's always room to study on this topic, obviously, but areas where you're passionate about, or where you think we really should be focusing, and then I'll ask Saqib to follow.
Yeah, this paper does a great job of mentioning ways to leave behind local antibiotic, and there is, again, increasing evidence. I know the big sort of European infection consortium for trauma sort of showed that risk of recurrent infection after a fracture-related infection surgery, leaving behind some sort of antibiotic depot was like the one thing that really seemed to correlate with the decreased chance of recurrent infection. And I think we leave the same antibiotics over and over and over again, right? Vanc, Tobra, Gent, things that we've been told as trainees are going to be heat stable and polymethyl methacrylate cement, but we're putting them in depots. Maybe it's calcium sulfate that, one, aren't exothermic, so they're not heating up when they're drying, and two, I don't know how much people have actually looked at the activity, the biologic activity of other formulations of antibiotics that we could potentially be impregnating into polymethyl methacrylate, because there's also increasing evidence that coating implants when treating type 3 open fractures, like doing a primarily antibiotic coated tibial nail, may decrease the risk of infection and non-union in type 3 open tibias. So to area of investigation is, are there other types of antibiotics that we could be impregnating into cement with other spectra of coverage that we're not currently using? And obviously that's not just for acute open fractures. If someone has a fracture-related infection you're trying to treat and you know organisms, do you have other options that you could impregnate? So, you know, put a bunch of stuff in polymethyl methacrylate and then take the effluent off of it and see, you know, if those antibiotics are still effective after they've been through that heating up process. Pretty easy study. I haven't done it.
That's compelling. It's very compelling. Very compelling. Saqib, what about you? What do you think, based on what you've done, not only in this paper, but just your broad experience in this space?
Yeah, I agree. I think with what Dr. Fram said, I guess maybe I'll simply state, I think it's all going to be about improving antibiotic delivery. I mean, we know that antibiotics, given early, seem to be our best friend here. Local antibiotics have reasonable evidence. So, you know, Dr. Fram mentioned a couple of strategies. Should, you know, if it's all about improving antibiotic delivery, should it already be there? Should it be on the implant? Should we be giving more antibiotics and for longer in prophylaxis manner? I mean, we sort of do this 24 hours thing. It's just, is it dogma? I mean, maybe it should be 3 days or 5 days, or maybe it should switch after a couple of days because we know, you know, later on you're going to be getting nosocomial infections. So I think it's all about improving our antibiotic treatment and delivery, both systemically and locally. And there are some investigations. Dr. Fram is probably aware, I guess, being at Carolinas, about some of the metric studies looking at, you know, I think Sextant is one of them.
Yeah, and, with putting Tobra in addition to vancomycin to see if they can show what they showed with the Vanc trial, but with gram negatives.
Right. So we may have some, you know, we're enrolling patients in that. I'm sure Carolinas is probably one of the lead centers, and hopefully in a couple of years we'll have some results. But yeah, I think it's all about improving antibiotic delivery somehow and figuring that out better.
That's compelling, guys. Great topic, I think, to go forward with, and hopefully we'll continue to expand in the space. Let's end here. I want to thank you both, Dr. Rehman, Dr. Fram, for the discussion, for your expertise, your work on this paper, work in the broader academic arena, your teaching to house officers, residents, fellow students. At SurgiColl, just closing with this, we believe that broadly open access publishing is the future of scientific publishing. It keeps costs down, it allows the authors to maintain ownership of their work, and most importantly, it facilitates expeditious dissemination of the author's research, like this research, to anyone with internet access around the world, with no requirement to purchase access or pay for a subscription. So that's our mantra, and we really appreciate Dr. Rehman publishing his article in SurgiColl. We appreciate Dr. Fram sharing her expertise. So thank you for joining us. Till next time.